Hi, good afternoon, everyone. Thank you for joining today. It's 2:02 and I see the number of people joining is still going up. So I'm going to give people one more minute and then we'll get started. Okay. It looks like it's sort of leveling off. So again, thank you for joining us today. So we're, excited to share with you our progress on our project that is for restructuring addiction services funding. We know that there's a lot of interest. I know, when I've had discussions with providers and local government units that, this frequently comes up about where are we, what's happening, what's going on. And so we're just very happy to share with you about what's going on and have an opportunity for you to ask questions and really hear from us. So with that, I'm going to turn it over to Debbie Davis.
Thank you, Chinazo, and good afternoon, everyone. I'm Deborah Davis. I'm the Associate Commissioner for the Division of Fiscal Administration here at OASAS, and we'll get started. Next slide, please. So just a few housekeeping items, right? This is being recorded. The recording will be available on the internet. There's an RASFP website on the OASAS website. So we'll be sharing it there. Your lines are muted. To share comments and questions, please use the chat function. Also, actually, all the questions, whether we had a chance to answer them on this call or we have to answer them later, will be shared on the Q&A document that we have already on that web page. We would just update it with today's date and provide all those questions. And then we're going to send an email out to you all alerting you to the fact that that has been updated. So next slide, please. And just for ease, where is that restructuring addiction services funding project webpage on our website? Well, you can find it using this QR code. That's kind of cool. Or you can just put in RASFP OASAS into your search and it'll come up that way as well. Next slide, please. So our agenda for today, for providing an update on our project, we're going to, review the project again, level set, talk about the phases of the project, talk about a lot of the community input that we have had thus far, and also other, data that we've been looking at. And then, of course, next steps. Next slide, please. So let's review the project. Just as a reminder that net deficit financing rate is approved budget expenses minus all revenues equals a net operating deficit if there's money that were expenses that weren't covered by those revenues, right? So we talked about at the last update what were some of the advantages of net deficit financing. And that is that it supports uncompensated and underfunded care. It subsidizes costs that aren't adequately reimbursed. It provides funding for services that don't traditionally have a way of generating any revenue. And it's advanced, at least here in New York State, we advance state aid and it assists in addressing cash flow issues. And just also as a reminder, state aid from OASAS includes general fund, some special revenue funds, and the federal substance use block grant. For New York State, we provide the most state aid, in the country. We are close to 500 million, where the next in line is California, which is almost 400 million. Next slide, please. But there are challenges with net deficit financing, right? There are historical budgets that are not providing an equitable or consistent reimbursement for the same services. There are older programs that receive, different funding for similar programs that aren't consistent with newer programs. So that creates inequities within, the type of service, even within the same geographic area, even, in the same city or on the same block, potentially. There's no fiscal incentive for administrative or program efficiencies, and it can be inconsistent from year to year, especially when you're doing your, annual closeout. So next slide, please. You may remember this infographic if you were on our first presentation, but this really is just a pictorial, a quick snapshot of what the project is. We engaged a consultant, Third Horizon Strategies, with the goal to develop a modern and equitable financial model for addiction services in New York State. This consultant is an objective and experienced, organization, and is engaging, conducting, as you look at the circles going from left to right, they are engaging, conducting surveys, focus groups, we're doing updates, and we're, receiving feedback and, in a loop here where we're doing research, we're reaching out, and now we're providing you this update. And so we're providing resources such as the webpage, and that's going to house the updates and recordings from, calls like this. And it also, we have a mailbox, the RASFP at oasas.ny.gov, which is shown in the upper center circle. And then, there is a timeline to this, right? And so we did have a projection of what that cycle looks like, and we'll be sharing that again. But the product is that we will be, at some point within this 5-year engagement, we will be implementing a modernized and equitable financial model addressing the priorities of the agency and hopefully yielding, improved delivery of services. Next slide, please. So let's take a look at the project structure, phased approach. So, in general, what we're looking at is like a repeatable, projected cycle timeline. We have done a lot of research and engagement, and so we've adjusted the timeline, and I think this is common with projects. You start to peel the onion and you realize you want to look at more data here, or there's gaps in data, so where can we find other data that could fill in that gap? So that's part of what's happening. So but essentially, we're doing research, we're engaging with stakeholders, we're looking at potential frameworks for alternate funding mechanisms, and then we'll start to develop those a little more, again, with feedback from you all, and, and then put something forward for, implementation, and allowing a very long process for that because there's a lot of work to do to make any types of changes. So next slide, please. And just wanted to share with you because when we talked about it before, we didn't really have the services kind of categorized together. But, just sharing with you that we were looking at key dependencies and interrelationships between the service types, kind of related to similarities and differences, maybe if they are revenue generating or not revenue generating, how much of the state aid funds those services related to other services. Are they clinical, non-clinical? What's their fiscal vulnerability and or complexity? So we're trying to group similar things like that together. And so we came up with cycle 1 is really big. It actually deals with like 65% of our state aid, but we had to break it into 2 components, mainly focused 1A on outpatient, 1B on, inpatient or what we consider bedded services. Cycle 2, as you can see, is crisis, detox, housing, and other, treatment supports like case management, family support, navigator, peer support, etc. And then cycle 3, prevention resource centers, problem gambling, resource centers, recovery, which is recovery centers, youth clubhouses. So in no way is the order indicative of anything other than we really decided to go for the largest amount of, what's funding is going towards, because we thought, let's dig in and spend the most time up front. And so that's what's taken so long. Next slide, please. So let's talk about the community input so far. Next slide, please. So there was an online provider survey that was sent out to all OASAS funded programs. And it was a voluntary electronic survey. It was administered between December and January. We extended the time frame for a couple of reasons. One was it was, the holiday kind of came in the middle. But also we were really trying to increase the amount of providers that would participate, and complete their surveys. And this was new, so there were some hiccups where, someone would lose their link, or they started the survey and didn't know how to get back in. And I have to say, and I hope that anyone who's gone through this process feels the same way, but I really felt like our consultant was right on top of really addressing any questions or needs that you had that came up from an IT related way to get into that survey. And they did a lot of outreach to try to get the providers to participate. We, out of 344 OASAS funded providers, 144 completed the survey, and that's around 42%. And we know that you really had shared with us that you wanted to be engaged in this process. And so we made every effort to make sure that you were. And although, although it is, from a survey perspective, it's pretty good from those bases, but we were kind of hoping for, more. So, but the good news is that there was pretty good representation. So the, we had a number of providers respond that, get funding for one program. You can see from 2 to 4 programs, 5 to 8, and then 9 or more. There is going to be a second survey going out to the OASAS certified providers that are non-funded, or that it has been out there. So you've been contacted, and hopefully if you're on this call as well, that you are seeking that out. And if for some reason you don't see it, then please reach out to the mailbox, and we will make sure that you receive the link. It is coming from Third Horizon Strategies, so it won't be from OASAS, but we did send out provider announcements, to the certified non-funded providers, so that you would be looking for the Third Horizon Strategies link. And that's what we did with the first survey. So just know that that's out there. Next slide, please. So we, just a snapshot to take a look at, from the Cycle 1A group of providers that responded. Like I said, we had 42% of providers respond, but for the 1As, we got good representation across the state of providers, and the size excuse me, the size of the circles kind of indicate how many providers responded in that area. The smallest circle really indicates about 1, and then it grows from there with the larger circles. And you can see that there were a number of providers that responded from the 5 boroughs. There was a strong response from there with the outpatient, and that makes sense to us. But we had 89 respondents that responded in this area for the 1A cycle of services, which again was all of outpatient services. Next slide, please. So we also want to take a look at what were some of the things that we learned from the group of providers that responded in the 1A group. And we took a look at the top 3 strengths that were noted about net deficit financing, and that's what the NDF is. And what were the top 3 challenges, and then what were some of the anticipated transitional obstacles that folks were indicating. And so from a strengths perspective, the ability to serve all individuals because of receiving state aid is a benefit. It offsets costs for services not adequately reimbursed, and it funds care for individuals not covered otherwise. What are the challenges? The payment structure doesn't cover all the costs. Administrative complexities and or burden, and we'll talk a little bit more about that when we talk about the focus groups I met, because they were able to dig into that a little bit more. And then compliance or reporting challenges. Anticipated transition obstacles. The top one was risk for a variation in funding, administrative burden, and other. Some of the other comments, because you could type in, were that they may not be able to admit commercially insured or non-Medicaid eligible individuals because cannot cover costs. So worried that funding will get caught, in a change of moving from net deficit to some alternate funding, and then that would not allow them to pay for, right, non-Medicaid individuals. So this is kind of, so there's a slight variation when we look at the results for the 1B group. So next slide, please. Okay. So for the 1B group, which was our bedded services, we had a little less, in the first group, I think it was like 89 respondents. We had 63 here, but still a decent enough distribution across the state, which is, very good. And these were the program areas that the respondents received funding for, who responded. Next slide, please. And then here, something to note here, there's 4 strengths here because they were so close in, how high the respondents, gave. So again, offset costs for services not adequately reimbursed was seen as a benefit of net deficit financing, ability to serve all individuals, funds care for individuals not covered otherwise, and the advanced payment approach. So for bedded services, that was very helpful for them and was seen as a strength. Challenges: payment structure does not cover the cost of services, compliance or reporting challenges, administratively complex and burdensome, and anticipated transition obstacles, risk for variation of funding, administrative burden, or other. And I'll just share that the comments under other in this group of the providers same thing, may not be able to pay for uninsured or non-Medicaid eligible individuals because cannot cover those costs, and receive limited funding from other sources. So, there's lots of commonalities, but interesting that this group focused in on the advanced payment approach being important. Next slide, please. So there were focus groups that met. There were 2 meetings, and this was held by Third Horizon Strategies, and they provided to us a list of 2 groups of providers based on one group that received a lot of Medicaid revenue, and the other group that really relied more on their state aid as a revenue source. And so they provided us the full list of those and wanted to really look at making sure that providers in the focus group represented the full state, so that we had, representation from each economic development zone across the state, as well as wanted to make sure that we had larger, larger organizations from a funding perspective, medium-sized and smaller. We wanted to make sure that, sometimes there were providers that were really representing a certain area in the outpatient group, but they also would be really good in the bedded group. And so, we are the 1A focus group, just as a reminder, was all outpatient services. So the focus group for the bedded services is going to be coordinated in June. And so, if you're falling in those categories, you may be receiving communication to get those meetings set up. But really, it turned out that the 1A focus group, that there were 17 in the first group, which was the high Medicaid revenue generating group, and 22 in the second group, which was a high state aid group. And it was a really robust discussion, and captured in these boxes here is the current financing structure, provider experience is disjointed as different funding sources are managed differently. So good feedback that, you receive state aid one way, but you might receive a different funding source, a federal grant or, opioid settlement fund or something, and you do have to manage it differently. And we do understand that sometimes that can be complicated or confusing. And so we try our best to make sure that you're aware of the funding sources and what's expected. Providers are struggling with the administrative burden and the multiple layers of reporting between state agencies and county governments involved in distributing funding or third-party reimbursements. And so that, those are definitely administrative challenges. I mean, we feel some of it too, because everybody has a different system to report in. And so we are looking at always ways to streamline that. And we have developed some answers for that you'll be hearing in the near future, if you haven't already. State aid administration statewide through counties is inconsistent, especially noted by providers with contracts from more than one county or contracts. And we are working, that's the part where we are working on how contracts are developed and, how budgets are, put into the system, into SABRs and so forth. So we are trying to make streamlining changes where we can. NDF functions more like a capped grant award and does not cover the full deficit for some providers. And that is very true. And that would be true of state aid in general, right? Because we have a capped appropriation and we wouldn't be able to cover, all deficits. But we understand that that is challenging. Methods to transition away from the existing NDF methods should consider actual cost, better coverage for uncompensated care, and incentive efficiency while supporting organizational health and stability of providers. I couldn't have said it better myself. That was great feedback from the focus group. Any transition should be incremental and phased in over multiple years to not materially disrupt the existing system. Very good point, and we're very well received. And so anything that would ever happen would be phased very slowly. Your historical budgets would be maintained for a very long time. And so I just, as we move forward in the slides, I just want to make sure that that is heard because I'll be saying that a couple of times. But absolutely, we do not want to destabilize the service system at all. Okay, next slide, please. So other data and research, because really we've been, the Third Horizon strategies, as well as when we're being asked for material, we have been working really, really hard collectively, as well as, the time that you all put in to fill out those surveys and to participate in the focus groups. Next slide, please. So some of the data that the Third Horizon strategies and the actuarials that they hired have been, looking at is multi-years of Medicaid billing, right? The 2019 to 2022, looking at all of the OASAS payment codes and the Medicaid received for, every provider in that time period, the number of services performed for each code by the year, the number of patients served, and the aggregate amount of Medicaid payment received for each code. Also looking at consolidated fiscal reporting data, which many of you, or if not all of you, are familiar with, right, as the standardized reporting method. And the data must be completed by service providers that receive OASAS funding. And so they're looking at that data, cross-referencing it with the Medicaid data, and also cross-referencing it with our client data system, which is the online reporting system that tracks SUD patient admissions and discharge. So you can see there's just a lot of data being looked at. Next slide, please. For, this slide, I really just wanted to share that there's a lot of other research and information and interviewing going on There's engagement with academic settings that are doing research into, quality and evidence-based measures for SUD services and funding. There were meetings with behavioral health care collaboratives, representatives from provider associations. There were 4 structured other state interviews, and that included their SSAs, their single state agencies, representatives, and a literature review for another 10 states, digging into how is their state funding provided, including how are they, providing their federal substance use block grant funding. Outside legal consultants were hired to review New York State statute regulations regarding state aid, as well as reviewing all the federal statutes and codes for the substance use block grant. So a lot of that background has been done. And just a brief summary, these bullets are just talking about when taking a look at all the data, especially, comparing states to states, these are some of the mechanisms, right, that we've been looking at and of how they're provided in other states or by other state agencies, because other state agencies also were engaged. So fee-for-service Medicaid rate matching, right, that I think goes without saying, you're using the Medicaid rate. And, this kind of is very interesting now because, we got the change in statute where commercial insurance has to use the Medicaid rate starting in January 1 of next year. So that's definitely already in place here for at least our Medicaid work, but this would be, using that to pay out state aid. Voucher-based funding with uniform rates. This is other states are using where you are providing a voucher that the service was provided and you get provided a rate back, and it's on a reimbursement basis. Some states have hired intermediaries, which means some of the state aid pays for that administrator, and that administrator manages, in some cases, manages their managed care. It also manages uncompensated care pools. Some of the uncompensated care pools have eligibility requirements, so people are looking at that before they make the payment back to the provider. It's it's complicated and it doesn't allow for an advance, but just sharing with you things that we've looked at. And other states just provide state aid grants and that are based on specific outcomes and utilization measures. So what I want to share here is that from here, what would be the next step, right? We've looked at a lot of information, and not like that we've stopped looking at information. We will continue to do that, but what is the next step? So next slide, please. And next slide again. So really, keeping in mind what I said before, that we have a capped amount, right? And we want to ensure that we distribute state dollars in a way that's fair and equitable and modern, right? Because I think one thing that I didn't say when we were looking at all these methods is none of them said net deficit financing, right? So it could appear that New York is behind in matching its funding to where we want the services to be, right? So, or where the services are. Much has changed in the last couple of decades, but we haven't changed our funding. But we want it to be delivered in a fair and equitable way and a modern way that supports vulnerable New Yorkers to receive care across our continuum of, network of services. So what are the things that we say? We're asking ourselves after all this review, how can OASAS continue to support services for the uninsured, populations, all right, while ensuring that providers have resources that they need to continue to operate? That's the main question, right? And how can we also equitably distribute the annual appropriated resources in a way that addresses social determinants of health or enhances outcomes or increases provider infrastructure and capabilities, right? While considering also your historical funding amounts. So those, we feel, summarize our 2 big questions. Easy answers, right? Okay, next slide, please. So we tried our best to do a pictorial of like an example of some potential frameworks. And what we're saying here, just want to highlight again, there's been no decisions. We haven't picked one. So the number 1, 2, and 3 doesn't say this is first, this is second, this is third, they won the prize. I without thinking, just, made it like that, those are our buckets. But, any bucket that we choose would be phased, right? Because we have historical budgets that would remain in existence and slowly phase into implementing one of these frameworks or other frameworks that we're looking at too. But these 3, I think, resonated with us to share as examples of what could be potential frameworks because of the responses we received from the surveys, as well as, talking about them more in the focus groups. Pretty much 100% of everyone said that state aid was really important to you because it helped fund uncompensated care, right? So, the basic idea is to pay for every single visit that didn't have a payer source. But we also want to ensure eligible patients are enrolled in Medicaid. So we got to find a balance there of how do we do that. And again, commercial insurances will have to pay the Medicaid rate. So, those are really good ideas to think about, because we feel that's a great use for the state aid, right? Is to make sure that we're addressing and we're hearing you, and we can see that in how state aid has been used. The other thing too, which I want to make clear, because I know that I didn't, when we say equitable, right? There are some certified not-for-profit OASAS providers that are receiving funding. And there are some certified not-for-profit OASAS providers that are not receiving funding. We feel we need to address that. So we have a capped amount of appropriation that we would like to make available across the state, right? So we have to come up with a fair way to do that that helps address uncompensated care, right? But also another framework is we have to make sure it addresses program focused, and program losses, right? Because there are, your current funding you're receiving is paying for losses, and there are, individual circumstances that, result in a loss. We want to make sure that we support that, right? So when we say, program enhancements, we're sure that there's enhancements, or there's, increasing provider capabilities, or paying for data reporting, but also paying for losses. And so that's part of this pool and this framework as well. But another one is also, and this would be, new but out there as part of what has been talked about, is we would like to find a way to, provide funding to support the underserved populations, social determinants of health, geographic, community demographics that, are not being served, or, we want to enhance the ability to serve. So I think these are examples of frameworks that agree with the feedback we got from all of you, but also agree with our strategic plan as an agency. So I've talked a lot. I need a drink of water. But I think the next slide talks about what are the next steps, because it doesn't end here, right? I hit the big kahuna on that last slide, but that's not where it ends, right? So we're starting to look at this, and there's a lot of groundwork that has been covered, but more that we need to do to help us map out how would we operationalize any type of new funding mechanism, right? Because there's internal things OASAS would need to do. There's external things providers would need to do. How do we develop models to look at? And we need your feedback, right? A continued feedback loop. So we are continue with the surveys, the focus groups, the town halls. We are, going to answer these questions. We will accept additional questions. There will be no change without showing what that would look like, and getting feedback, and being really thoughtful about all the changes that would have to happen. And your funding is not going away. it would be phased, and we would be really transparent about how that would happen. But I don't have those answers today. But I did want to bring you up to speed with where we are. And that's it.
Great. Thank you very much, Debbie. And I see, some have put questions in the chat, so please feel free to put any questions or comments in the chat, and we'll work our way through. So I think if we could take the slides down, that would be helpful. And the first question is the first project taken on by this initiative to develop an alternative to net deficit funding?
That is the definition of the project in its entirety. It is the only project is to develop, an alternate option, funding mechanism to net deficit funding. Now, but it may not mean that, everything about net deficit funding would go away, right? That's what we were trying to go over. But yes, the project is to do that thoughtfully and comprehensively, and sometimes service specific, right? Because maybe what we might come up with for addressing outpatient or bedded services wouldn't work for recovery or for gambling. So that's why it's a very long engagement for this type of project.
Great. So I think this is for the surveys, Debbie. Did multiple people from the same organization respond, and was it restricted to one response from each organization?
It was restricted to one person. I have to say, really, our partners with the consultant were excellent. And one person was always recognized by the organization to respond. We did, in our communications, we shared that, we recommended it was a fiscal person, but it didn't have to be, but we did say it has to be one person, and we controlled for that.
Great. So one comment is from the LGU, and so really stating the LGUs, are in the position to conform to whatever funding model is eventually chosen. And so will there be specific outreach to the LGUs during this process?
I'm so glad the LGUs are on because, or at least one, because I don't think we sent this out because we did it in two. So actually we presented to the LGUs on our first update. And so I was planning on doing this again to the LGUs through Courtney. So we've been giving updates to the LGUs. So absolutely, you guys are included for sure. And we need your feedback as well. So
they are being included in focus groups.
And you are being included in the focus groups as well.
Great. So a comment about the data that is, sure it's not lost on you or us at the state, but that because COVID, really had a huge impact, and so it's clearly impacted the data for 2020 and 2021, and so just making sure that we're taking that into consideration.
Thank you for raising. Absolutely, we hear you, and that is definitely taken into consideration. Thank you.
Another comment about the term that should be used perhaps is undercompensated care. And then if we're even if we're billing and are efficient, the cost of providing good care requires few positions that do not cover their own costs at current rates. So particularly the prescribers.
Yes, uncompensated care pools, not all of them do. You're right. But our intention is to include underinsured as well as what we would want to take a look at and provide funding for. Absolutely.
Great. This is not related to this specific webinar, but I'm going to read this because I'm also very proud of the comment about seeing the program regarding fentanyl, that it's very, very well done. I hope many people saw this, and I see that John was flipping channels and came across it, and it grabbed him in and captured him. And so, kudos to us at OASAS. I think I appreciate that comment. So I hope people have seen there's starting last week and going through, I think, the next few days, really all across the state on multiple channels, is really a lot of focus on increasing public awareness about fentanyl and also increasing awareness about the tools that are available that are life-saving. So the free fentanyl and free fentanyl test strips and xylazine test strips and the free naloxone that's available on our website. And that we have already received over 100,000 naloxone orders and over almost 16 million drug test strips have been shipped out. So clearly there's a huge need, and we're very proud of that work to get those harm reduction and life-saving materials out to New Yorkers. So just as a plug, look for this. The program is still running kind of in the 7 to 7:30 range, and the specific TV stations and areas are on our website for more information. So thank you for acknowledging that. There's a lot of hard work that went into that. Another question is there a way to volunteer for the 1B focus group? Debbie.
So, Ed, I'm gonna respond to you offline. I don't know what agency you're from, so I want to look. They haven't received, we haven't sent out the notices yet, so I don't want to, commit until, we have that. But I will reach out to you separately. Would you do me a favor, Ed, and let me know what organization you're with and a phone number I can reach you by?
Also, I just want to comment, really, we're being very, very thoughtful and purposeful around who's at the table. And I actually don't take this very lightly at all, because I think like the voices at the table really matter, and we want to make sure that we are really getting a diverse perspective that takes into account all the diversity across New York State. And so I know Debbie mentioned this before, but we're looking at making sure all the regions are represented, making sure the different types of programs are represented, making sure, right, so the different kinds of services in the continuum are represented, making sure that the big programs, the medium-sized programs, the small programs, the ones that do, bill Medicaid at high rates, the ones that get a lot of state aid, right? So really, like, we have this, we're really looking at like many levels to make sure that we're getting representation across the state. So even if you're not chosen, I just want to be sure that people understand that, like, we didn't just like randomly grab names or organizations. We've been really thoughtful about this process to make sure that it represents the whole continuum and the whole state. So just want to put that out there. So a question, are you giving any consideration or weights to programs running integrated services compared to traditional SUD services?
So thank you for that question. I'll share with you that you are more in the weeds than we have gotten. So we are looking at, in all seriousness, I shared with you that we're being very transparent about where we are. We are looking broadly at different frameworks of how funding is being provided. And then as we dig into different funding mechanisms that we think, would be better suited to meet the needs of our providers, who've provided us the feedback through the surveys and the focus groups to say, this is where we think state aid money, that this is where we need it to benefit us the most. So when we start looking into that, we will be asking, various questions on how will it work and how will it be best rolled out and, what it should fund. We're not there yet. So, but I will keep that on the tick list of a question for us to ask. Thank you.
Great. Just going back to the public awareness show, is the video going to be on YouTube? Yeah. So once we have, I think, so it hasn't fully aired yet across all stations and across all regions, but once it is, we will try and get that YouTube video and then send it out to all the programs. So appreciate that. Appreciate you all sharing with your, with the people you serve in your communities. So Okay, another Debbie. Seems to me that the new models being considered to be effective, cost of care and reimbursement rates would be important factors. Anything you can share on the work being done in those areas to date?
Yeah, I mean, I interpret the question related to, Medicaid rates, and we have done an enormous amount of work. I'm really proud that we were able to get, BHET dollars and reinvest them all into OASAS services rates to the tune of $70 million were invested. And also those rates are also being increased for the COLA as well. So we're very excited about that, and we continue that work. We're also on and I'm glad that you raised this question because I forgot to say so many details that we were looking at. But one of the things that the consultant is looking at is where do our rates stand across the nation? New York's always been a leader, and where are we with SUD service rates? And, that will help us in moving our agenda forward, with Medicaid. So we are on it, and look forward to being able to make more investments there. So thanks for the question.
A question about, can the current indigent care pool that's available to public hospital systems be made available to OASAS programs to fund care for the uninsured or underinsured?
Yeah, I mean, I think that it really depends on what funding. I mean, there are some funds that we have contributed to related to hospital, but by and large, for our state aid, we're trying to make our state aid available, in a way that would be more thoughtful about being used to support providers as they provide services to the uninsured and underinsured, right? So we wouldn't be able to use the hospital because it only funds those that are in an inpatient setting, right? And the appropriations are in DOH's budget. So, there are certain care pools that we contribute to, and it helps fund OASAS services within those care pools. But by and large, our state dollars, as I shared before, we're putting out, $500 million a year. So, this is about taking care of, our providers with those funds.
Question about, is it still on the table for discussion around private insurance starting to pay fee-for-service rates, or is it actually official?
Yeah, it's official that, the commercial insurance companies will have to pay the Medicaid rates starting January 1, 2025.
Yeah, and I think that leads, the bigger question in our heads is around enforcement, right? So that's not, that's an area that we work with our sister agencies on. But I think, the parity issues all around, are big issues that, again, we partner with our other state agencies. So I think this is a really important change, very important change, right? And it's very positive, and we want to make sure that that this change gets enforced. So we'll more on that as we move forward. So a comment, I echo the reimbursement concern and ask not only that I ask that not only that be considered, but holding the payers accountable for paying those rates is a huge issue. Yeah, exactly. We're with you on that 100%. Next question, can OASAS provide billing guidance to providers as we move forward so that the providers can bill to their best ability and maximize potential revenue?
Yeah, I mean, I think that between Pat's group and my group, we are trying to do that, and we will continue to, provide, guidance on that. And we look at, and I think we look at how our service codes are being used, and we can identify problems there and get word out to the community as well. So that's absolutely what we do.
Do we have a projected timeline for cycles 2 and 3? Oh, you're muted, Debbie. Oh, okay.
I'm flipping pages for my slides. The projected time frame is to start looking at, cycle 2 by, late summer, early fall, and digging in, and it'll be research, and then eventually there'll be the survey and focus groups, so we'll be following the same sort of pathway, but probably not until next year will people start hearing anything about that type of, information.
Yeah. Another comment about not only parity, but also in terms of payments that are covered by commercial plans. So yes, totally agree. Parity between physical health and behavioral health, and then also, between commercial insurance and Medicaid. So definitely hear you, agree with you very strongly on that. Another comment, technical assistance to maximize billing would be greatly appreciated, especially for billing for items that are not explicitly listed in the APG manual, and also discussing variations between Medicare and Medicaid and what rules to follow, as it always leads to confusion. Thank you. We hear that. I'm not sure if there's any more comments or questions. I know there are many people, over 140 people on this WebEx. Great. So would commercial insurance also have to pay for residential, as does Medicaid?
No, it doesn't apply to residential. It's for outpatient.
Okay. And then there's just comments about appreciating the updates and appreciate the opportunity to ask questions. So, we appreciate you being here. We appreciate your piece in this process. As Debbie had mentioned, it is really important that we get your feedback, that we get your thoughts and your perspectives. And there are many ways to do that. I think Debbie had, said, you can email the RASFP email box. Please look out for surveys that are coming and opportunities for, focus group. So, and, obviously this is ongoing with the different cycles and hitting different parts of our system and the continuum of services. So we really, really want your feedback, and, we'll continue to have these updates as we're moving forward. A question, is there any protection built in to protect third-party revenue generated that isn't deducted from OASAS dollars?
So I appreciate that question. And that gets at the heart of net deficit financing, right? And so, this gets to, one of the categories of the examples of potential framework is looking at, there are going to be program losses that need to be funded, and not to the detriment of, saying that you wouldn't get money because you got a revenue, right? Because you have to stay whole. And so we do recognize that, but it's a question of how do we do that equitably and open our funding up to more providers, right? Because that essentially is we're saying our state aid should be provided to all of the not-for-profit certified providers. So so we have work to do. We don't know the answer, but we're asking that same question. So thank you for the question.
Yeah, I also appreciate this question because it's sort of, thinking at a very, very high level of what is net deficit funding incentivize and what is it not incentivize. And we want to incentivize, obviously, good care for those who are uninsured or underinsured or undercompensated, and also for programs that are doing well. Like, we don't want to penalize those programs, right? So I think again, for Debbie, how to then do that? I think that's like the $1 million question that we're trying to figure out. another one, did I understand that you say that other states have phased out net deficit funding in favor of more modern processes, or are you thinking that maybe we are behind in our methods? Is it possible that we are ahead of other states with net deficit funding?
Well, that's an interesting question. I've not had it posed to me that net deficit is ahead of its time, but I would share with you that, no, I want to clarify. What I was saying about the other state research was we looked at where they are currently. We didn't do a historical view of how did they get where they were. So I can't say whether they ever had net deficit financing or not. So I just want to clarify. I don't have any idea if a state ever had net deficit financing. All I can say is under the states that we reviewed, we did not find any states that provided their state aid or their federal block grant by means of a net deficit financing, financial mechanism. So meaning that they just, provided funding for a program and then looked at, your revenues and then took back state aid if you got more revenues than your expenses for that year, right? So none of them do that, that we were able to see. And so I was, maybe being silly, but maybe not, in saying that, the give and the take back of net deficit causes disruption for the majority of the field. And I think it also, to the question that was just prior to yours, you don't get to keep, revenues make you forfeit state aid, right? So what's the benefit of becoming more efficient? And I don't mean that, and I don't mean to indicate that people aren't becoming efficient. I'm just saying that it's not a driver, right? So how can we benefit our whole system by providing funding in a way that helps you fund? The most important thing was your uninsured and your underinsured folks, as well as your program enhancements, your program losses. So that's really what we think we need to address.
I would just also add to that is that, there have been as you all know, there have been major shifts in the landscape, right? In terms of what's happening with substance use and addiction. And we need to move as the world is moving in every way, right? And what our programs look like and what our regulations look like and what our funding looks like, right? And so I think that this is important, and we're looking at this at a lot of levels, and funding is one piece of that, but it's really about an eye towards the future, given that the world has changed, the world that we live in now. How should we be moving forward? What do the services look like? What does the model look like, right? And that's across the entire agency and across the entire field. So I think this is the piece with around the financial piece, but we're asking these same kinds of things in other parts, in other realms of the agency. And I think we have to, right? We have to, because the world is constantly changing, and make sure that we're keeping up with it, right? And looking forward. And so I think that's kind of our perspective as well. So a question, does working under a framework that all non-for-profit licensed OASAS providers will receive some form of state aid without a firm expansion of total state aid run the risk of diluting the state aid grants in such a way that all providers receive insufficient aid for uncompensated or undercompensated services?
Yeah, I understand the question, and it's a good question. I think that's why you have to look at modeling, right? And take a look at what is your total funding. And we can see, so we have the data to see what is our state aid funding now. We can look at all of the data, right, in the CFR and Medicaid, and say, we know from your payer information of the patients that are provided services, which ones are uncompensated or underinsured, and how much of the state aid is actually funding that versus how much is funding, program loss. And there are many programs that are not receiving funding right now that have no loss, right? So it's a matter of looking at, not everyone will need as much dollars, but the dollars that you do need, should be used, right, to fund what we'll decide it'll be. But it sounds like very much from the field and in line with our strategic plan that the uninsured and the underinsured is like the most ideal framework that we are really focused on. And then it's a matter of, in the program area, how to, fund that.
Great. I mean, I think these are really good questions, and we don't have the answers yet. Like we don't have the answer at all. This is, we are working through it, and that's why your input and your perspective and feedback is really important. And as Debbie mentioned, there's some examples of potential models, and we're feeding, going to be getting feedback from about those models, right, from the field, for us to really then think about, right, so what are these sort of more detailed issues and questions that are coming up, like what does it mean for this, or what does it mean for that, and doing modeling exercises. So I think these are really good questions, ones that we're also, very much on our mind as well, and we're working through, and really important that we're doing that with your feedback and input as well. So I think that some of the input will look different when you get to services that aren't reimbursed by insurance, things like prevention and recovery. 100%, absolutely. And that's why, as Debbie mentioned, we were really thoughtful too about the different cycles, because including billable services with non-billable services in the same cycle, they're different animals, right? And so how should we be thinking about them? How should they be different? That kind of thing. So definitely we agree with that. And we're not there yet on the non-billable services, but we will get there. But really thinking about them differently, we have to. So definitely appreciate that. Other comments, questions? Okay. Well, again, I just really thank you, Debbie, and your team, and really appreciate all of you for joining us today. And again, there will be many opportunities to provide feedback, and we'll continue to provide updates as we continue to move through this process. So thank you again for all of your work, and for joining us today.
Yeah, thank you.